Well, hello everyone. It's good to have you here. Today I have a friend, a mentor, and a terrific surgeon. I'll be hosting Ricardo Fontes from Rush University in Chicago. We met over 10 years ago, and since then we have very close. And I'm sure this will be a fantastic lecture. So, Ricardo.
Yeah, thank you, Alfredo. Yeah, appreciate the invitation. Appreciate the introduction. And yeah, it feels like ages ago, but it was only 12 years that we were here, and you know, a lot has changed. But you saw this. I'm going to talk a little bit about our experience with infections, and you saw a little bit of it 12 years ago, and you can see what it's become after this period. But thanks everyone for the invitation. I hope this is useful to you, and if there's any questions, just let me know. So I'm here to talk about pyogenic vertebral discitis osteomyelitis, the fancy name for just discitis, right? Bacteria discitis, and show how we navigate, provide some updates. This is something that is not talked enough about in residency and in training. So I'm at Rush. These are my disclosures. They don't apply. So as objectives, I'd like to review the current guidelines for the diagnosis, treatment, and follow-up of PVDO. Explain the rationale for minimally invasive diagnosis, drainage, and reconstruction. Also describe the fundamental aspects for the maximally invasive treatment of discitis osteomyelitis for the patients with those that had predominantly post-infectious deformity. So I'd like to, first of all, congratulate you all who are watching this lecture. This is certainly the most unpleasant topic of this lecture series. Okay, so if you're not familiar with the picture on the right side, if you're just starting your training, you will be. There are a lot of feelings associated with the picture on the right side, but it's if you're here because of a case and you're watching this because of a case, you're in a tough spot. The patients are difficult. The patients are miserable. There are social and medical stigmata of having discitis. These patients are often seen as, representing social values that are not considered desirable by doctors and nurses. They are indeed, sometimes they are indeed complicated, right? It used to be that the classic patient with discitis osteomyelitis would be a dialytic patient with end-stage renal disease or poorly controlled type 2 diabetes, IV drug users. What I'll show you is that our data here, at least in Chicago, what it basically means, those things have been dropped. Those labels are not so common anymore, but it overwhelmingly reflects poverty and psychiatric pathology in our society, among our patients. The attitude of other spine surgeons is they just want to distance themselves from this. Okay, if you're a junior partner in any practice, you will get the discitises. Okay, but other people want to distance themselves from these pathologies. Other physicians are overwhelmingly freaking out surrounding you. So infectious diseases is asking for source control, which is a great term, considering that the infection is metastatic to the spine. The source is obviously something else, somewhere else. Radiology is frequently reluctant to do a biopsy. They frequently push it. And anesthesia looks at the case and just says, "Are you kidding me? Seriously?" So that is the situation that you will find yourself when dealing with these cases. And last but not least, here in the United States, it is the #1 cause of medical malpractice lawsuits in neurosurgery, and actually in spine surgery too, when you consider ortho. So welcome. If there's any consolation, you should know that a lot of pioneers in our specialty have found themselves in this situation. And actually, discitis has spurred the development of new techniques. Like in any surgical subspecialty, war and infection have spurred the development of new techniques and new concepts that ultimately made our everyday life easier. One such example is ALIF. This was first performed for pyogenic infections over 100 years ago. You see, the case is already infected. So in that aspect, you have one less thing to worry about. Frequently, patients are already paralyzed. So in a sense, it's a perfect teaching case for any residency program. There are very low expectations as far as complications. And I'll tell you, I'll try to convince you today that these are the happiest and most grateful patients in my clinic. Not because my clinic is terrible, but because these patients are really much better. Those patients where you can make the most difference. It is extremely rewarding. And if your institution pays any attention to this, it is socially very important because you are treating patients who are coming from a less favorable aspect of social spectrum. So it is socially very important to be able to treat these patients. If you're going to set out and look at the literature and look at evidence, you're in trouble. Okay, if you go look at any textbook, the space devoted to Discitis and these infections is minimal. I'll give you the example of Benzel's edition. This was a current edition when they first prepared this lecture. It's got less space in the book than things such as Tarlov cysts, vascularized bone grafts, arachnoiditis, nuclear replacement. Things are not part of our day-to-day activity. So it is a topic that's not talked about enough. And the way that we decided to study this, it started almost like a joke. So we basically were situated in this urban area, an 11-county area here in the United States, in the Midwest, with about 9 million people, 4 academic centers. There's very stark, very fierce competition among these medical centers. And about 15 years ago, our cranial partners were struggling for cranial cases, and they created basically this hotline where anybody in a hospital could pick up a phone. We have direct access to our intensivists or our neurointensivists, and they thought, oh well, great, this will bring us a bunch of brain tumors, skull-based cases, epilepsy, whatever that's interested. Well, guess what? We were flooded with chronic subdural hematomas, falls from nursing homes, osteoporotic vertebral compression fractures, and Discitis cases, not forget the epidural abscesses. So it became, basically, we identified that not only there was a need, but also an opportunity, both at the local and global level, to be able to do a better job at our specialty, to be able to produce literature to guide us, and to better serve the patients and the population we have surrounding us. So we're able to start a database prospectively of Discitis cases, and we were able to accumulate 298 patients in 8 years. And we're starting to publish the first aspects of this database. What you see on the right are transfer maps and the correlation. That's a correlation with the heat map of minorities and of socially disadvantaged populations in the Chicago area, which is the first one of these publications that's soon coming out. But so we identified an opportunity, and I'll tell you, it's been extremely rewarding, and I feel we do a much better job of treating these patients once we organized everybody around this opportunity, and we're able to get people to make up this group that we call DICE, or Discitis Center of Excellence. Again, going back to the literature, trying to find some guidance, you will find about 970 papers in PubMed. What few neurosurgeons, though, and actually no infectious disease specialists know, radiologists, nobody knows, is there are actually guidelines, very, very good guidelines published. They are now in their 3rd edition. They've remained more or less stable for the last 8 years, which are the 2015 IDSA guidelines for the treatment of PVDO. And that stands for Infectious Disease Societies of North America. There are no neurosurgeons involved, but there were orthopedic surgeons involved in crafting these guidelines. And I recommend that everybody become familiar with these guidelines, because if you don't know the evidence available, you become a passenger. And you don't want to be a passenger in these cases. You want to be the driver. You want to be the actor and not the spectator of a Discitis case. As much as we're tempted because of the amount of medical problems, the complications the requests for emergent interventions, they all come to you. Nobody will call an emergent infectious diseases consult. No, they will call the neurosurgeon. So you better know the evidence. And this presentation is based on these guidelines heavily. So just to narrow down the problem a little bit, that we're talking about PVDO, or pyogenic vertebral discitis osteomyelitis, where we're going to be talking about primary infections, not postoperative infections, and pyogenic, and meaning non-tuberculous. Okay, so this is applicable. These are mainly bacterial infections. This is applicable to some fungal infections. We'll talk about them as differentials. But these infections, the bacterial infections, have been increasing in incidence, and the number of surgeries performed for PVDO is increasing every year. Just for comparison, brain tumors, their incidence about 6 per 100,000 per year. Discitis is about half of it. But you don't get nearly a fraction of the effort from the neurosurgical community towards research. You don't hear about a discitis group, just like you hear about the brain tumor groups or a brain tumor meeting and this sort of thing. You don't hear anything about discitis. The importance there are specialties devoted to it is definitely not proportional to its clinical specialty. And more importantly, the mortality involved is very high, and probably not because of any effects on the spine, but probably because of the comorbidities, because of the different medical problems. So 12% of every patient with diagnosis of discitis will die in the first year. The pathophysiology involves always the dissemination of a bacteria to the spine. As I tell every patient, every family, the spine is a sterile place, and the bacteria get there somehow, and usually it's through the bloodstream. So these are 90% of the time disseminated via the bloodstream, via Batson's plexus. And once they see the cartilage, it becomes a massive problem. So that's another thing that neurosurgeons don't know very well. Orthopedic surgeons tend to know a lot better. Cartilage tissue is very difficult to treat for an infection just because of the poor vascularization. Same is true for implants, right? I mean, when we talk about plastics and whatnot and how to reconstruct, I'm not going to go into that detail, but just so we as neurosurgeons, we can learn a lot from our orthopedic colleagues when we talk about how these implants live in the middle of an infected field and whatnot. But the bottom line is infection of cartilage is very, very difficult to treat in humans because of its poor vascularization. But a minority of cases can be due to contiguity or continuity. Okay, so these are two other types of infections. The most common example of dissemination via contiguity is pyelonephritis. So pyelonephritis with seeding of lumbar and thoracolumbar discs. So it's spaced immediately adjacent to it. And then as far as continuity, which is a direct spread of the same infection, then probably the most common example are esophageal tears. I mean, we see that a lot secondary during iatrogenic esophageal tears, but this is an example of a primary esophageal tear, and you can see the air outside of the esophagus and the pneuma mediastinum. The big difference, this is important in a sense that hematogenically disseminated infections and contiguity infections, they tend to be monobacterial, versus the continuity infections, they tend to be polymicrobial. And so that affects the antibiotic coverage, and that affects the way, we have to be stewards of the proper antibiotic treatment, because again, once these infections recur, you will be called not the infectious disease specialist. How do you investigate? So this is a big portion of why the incidence has increased so much. It's because doctors are increasingly aware. This is largely a consequence of the number of lawsuits, at least in the area where I live, which is one of the most litigious areas in the United States. Basically, any patient with neck and back pain and fever should merit investigation, and that's an MRI with and without contrast. Other factors that may lead to increased suspicion include elevated white count, elevated ESR and CRP, which are the biomarkers for increased inflammatory activity. They are by no means specific, but through the roof with back pain. It's discitis or epidural abscess until proven otherwise. Patients with endocarditis, especially those with right-side endocarditis, which correlates with more IV drug use, which is still very common here in the United States. Patients with neurological findings. And again, the other risk factors are classically associated with IV drug use, end-stage renal, dialysis, increased hospitalization, steroid use. MRI is the imaging method of choice. The alternatives are only considered when MRI is not available, not possible, or merely a historical note, like these inflammation bone scans, gallium or technetium scans, the nuclear medicine scans. CT is going to be frequently used as an adjuvant to try to understand the anatomy, try to understand how much bony destruction there is, which is important in the reconstruction of these cases. And PET scan is usually not authorized. It will detect the discitis, but it's not very specific, and it's not authorized here in the United States to be used for diagnosis of discitis. Everybody will get blood cultures, including the unusual pathogens. So that includes fungal blood cultures, include brucella, and you'll always try to include a quantiferin gold for to try to, if there is a differential with tuberculosis infections to be made. This is what you see on the MRI. So the main characteristic of PVDO is its multi-compartmental nature. That meaning that you have an infection that does not respect the different planes. So you have fluid in the disc space, you have destruction of the end plate, and you have a paravertebral component that can be the typical psoas abscess that we see, or we can see a prevertebral phlegmon, as in this case. All of this with contrast enhancement. So this is a T2, this is the T1 of that picture. You can see the amount of bone destruction. These patients, you should remember that this is a scan obtained in the supine position. That's why you have that gap where the disc was. Now it's destroyed. This is frequently a patient who will collapse the disc space and would not tolerate standing because of the kyphosis once you see that much of a gap. This is another example of a cervical discitis with kyphosis and a component of epidural abscess and cord compression. Again, fluid in the disc space, end plate destruction, epidural paravertebral component, and an avid enhancement by contrast. The differentials are very interesting. Some of them will actually end up being treated the same way as PVDO, but they need to be made, especially for the antibiotic management. So other forms of discitis, spinal tuberculosis is what you see on the right side. It's frequently, I got to practice, I was fortunate enough to practice in Brazil, so we used to see a lot of spinal tuberculosis. Here we see some mycobacterial infections. We don't see it that much get to this point, but the imaging characteristic of spinal tuberculosis is these discitises at different stages, right? So you can have healing and you can have destruction, and then you repeat the scan in 2-3 months, you can have the same thing happen at a different level. Usually there are contiguous levels. So you can have multi-level PVDO of bacterial origin. About 10% of cases of hematogenic distribution, they have multi-level discitis, but they're not contiguous like this case here, which is across multiple levels. You can have fungal discitis. So this is an example of an aspergillus discitis. Again, normally you would look for pulmonary findings. In the case of this fungus, every fungus presents a little differently. They tend to be a little bit more indolent and progress a little bit slower, but you can see here the imaging aspect is absolutely identical. So it's really important to include fungal cultures when you send your specimen. The people who usually forget this are the radiologists when they do the biopsy. Brucellosis. So brucellosis is another important differential. It looks exactly the same. It is, after all, bacteria. The important differential to make about brucellosis, we're going to see the treatment. You don't actually need to biopsy. If you have a strong suspicion for brucellosis, either because of identification on cultures and blood cultures, or you have a strong titer with of antibodies, with positive epidemiology, you can treat it clinically. That's part of the guidelines. You have the finding of amyloid spondyloarthropathy, which is a form of renal osteodystrophy that's dialysis related, bad dialysis related, right? So that's a form of osteodystrophy that's associated with multiple years of dialysis. It can present very similarly, except that DRSA does not have the multi-compartmental nature of Discitis. So you will not see psoas abscesses, you will not see an epidural phlegmon. You will see it almost looks like a dry Discitis or a worn out Discitis. These patients are not receiving contrast on their MRIs because of the risk of pulmonary fibrosis, but it can look very similarly. The patients have the same risk factors. So it's the main differential that we see here. The way to diagnose this is, first of all, you won't have the multi-compartmental features, but when you do your biopsy, you ask that specimen to be analyzed under serious red birefringence by the pathologist, and you can frequently see the amyloid in that manner. So that would be the way to make the diagnosis, the definitive diagnosis. You have to have at least 4 years of dialysis, and it has to be bad hemodialysis. It has to do, there are some things they can do, the nephrologists can do to prevent this. That include things like changing the membrane filter and that sort of thing, the porosity of the membrane. But for example, peritoneal dialysis does not typically lead to this. You have a blast from the past here, which is the aseptic Discitis of ankylosing spondylitis. This is a great example here that was treated initially as Discitis. Again, you need the patient to be ankylosed. The reason for this is that the ankylosis does not happen at the same time across every levels. So the thought process is that this is the last disc that remained open in the process of ankylosing spondylitis. And because of the lever arms, it just destroyed the disc, and there's excessive motion in between those two ankylosed segments, and it never got to fuse. Again, multiple negative biopsies here. In this case, patient has no pain lying down, which is very unlike the patient with PVDO, has the ankylosed features. And the most perverse thing is because the biopsy is negative, they're frequently on broad spectrum antibiotics. So they're taking 3 drugs for months and months, and they still have pain when they stand up and try to move. But this is a very typical picture. You just need to take the patient to the OR and stabilize. A great case for percutaneous fusion. So these work great. You have spinal neuroarthropathy or Charcot's joint. Again, it's the neuropathy of the paraplegic patient, that most commonly today. It was described in patients who get diabetic neuropathy. So you can have a multi-compartmental feature. You have instability, you have destruction of the end plate, and you can frequently have a hypertrophic form of Charcot's joint with a lot of deposition of calcium. So that's the differential. Discitis, if it's active PVDO, there's never calcium deposition. Charcot's joint, there will be an attempt of the body to heal itself. So there are these scattered foci of heterotopic calcifications in the axial views. And then finally, you have lymphomas and you have chordomas that can present the same manner. So this is a case that was read initially as an epidural abscess with a small Discitis at C6-7. It turned out to be a lymphoma, and then a chordoma that presents over here. Again, the pattern of osseous destruction is a little different, but it can frequently be mistaken for Discitis. So with these, once imaging is obtained, again, we try to obtain the diagnosis via demonstration of the causative agent. For patients with hematogenous or contiguity infections, we already discussed, these are usually going to be monomicrobial, and Staph aureus is by far the most common agent. So it's in our guidelines that biopsy of the Discitis level is not necessary when there is demonstration of Staph aureus or Staph lugdunensis in a 3-month period preceding the infection. The other case in which biopsy is not necessary is those areas of endemic brucellosis plus and strong serology, or you can sometimes even find positive blood cultures. That is in the guidelines. You can basically cancel that console note, go back to sleep, be happy about it, and let ID figure it out. Biopsy, some cases they're controversial, that there is the option of rebiopsying it, those patients with positive blood cultures from other bacteria. Then it's a risk-benefit ratio. In our experience, there's a 30% chance of a different bug being shown ultimately on the Discitis. So I'm sorry to say that as a general rule, most patients will still be biopsied in our institution, and about 30% of the time, these will yield us a different bacteria than the blood culture. The preferred method to biopsy and perform the diagnosis is CT-guided biopsy. Either you or the radiologist can do it. It needs to be sample needs to be sent in saline so that you can do PCR for mycobacterium. You can look for the ribosomal 16S fragment so that you can do rapid diagnosis of that mycobacterium infection. Otherwise, you're going to send it to mycobacterium culture. It's going to take 8 weeks to grow and blah, 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 and you guys know how that goes. You send it all to cultures. If you can send a specimen, if there's suspicion for dialysis-related spondyloarthropathy, you're going to ask for a serious red and examination under refringent light. If it is non-diagnostic, or if there is a skin contaminant, except Staph lugdunensis, which lives in our skin, you have two options. You can do a repeat CT-guided biopsy. You can do an MIS biopsy, or there's also the option of treating it empirically, although that's not suggested. There's a specific line in the guidelines suggesting a second biopsy. The yield of a second CT-guided biopsy is low in our series. It was around 20%. So we typically go to MIS biopsy. You can typically take a much bigger piece, and the yield is much higher. It approaches another 70% in cases that were initially negative. So it makes a big difference. So either endoscopic or tubular MIS biopsy is the best option in our opinion. As far as treatment, you will treat it empirically. If there is neurological compromise, you will start antibiotics. The patient is septic, but otherwise, you will hold the treatment until the biopsy is performed to increase the yield. It is debatable if you have that cavity, what point does adding antibiotics that really interfere with the yield of your biopsy? Would we traditionally just hold it? Antibiotic treatment, at least 6 weeks. There are some protocols that say 8 to 12 weeks for high-risk patients. So brucella, patient is on dialysis, undrained paravertebral abscesses, and MRSA, those staph that are resistant to methicillin, you can consider a longer term. And another point of contention, it's anywhere around the world, can be in China, can be Brazil, can be in the United States, Russia, whatever, is the question of how to follow up these infections. Idea, the doctors always want to repeat the MRI. It's like a basic tenet of spine surgery, that these infections will continue to progress on MRI despite the resolution or improvement of the infection. So follow-up is dictated by ESR and CRP, by the sedimentation rate, C-reactive protein. Any increase in C-reactive protein, if the patient is intact, you will not act upon it. You do not need to order repeat MRI. It's the second increase, the second week in a row where CRP increases. That's when you're getting the order imaging to reassess, and you start getting worried. But these things don't progress linearly. There can be isolated increases in CRP, and that's not a problem. According to the guidelines, what's considered treatment failure? Definitely not imaging. Progressive neurological deficits, that's easy. Development of instability or deformity is considered a treatment failure. Again, we're going to talk about how to address that. And failure to decrease ESR and CRP or recurrent bacteremia after 4 weeks of treatment. If by 4 weeks you're still having bacteremia, the same bug, just treat it aggressively, because we know where this is headed. So this is a typical case, 63-year-old patient, rheumatoid arthritis, steroids, with a history of septic arthritis, bacteremia, Staph aureus. We get called. Patient can't tolerate MRI. The patient is miserable. We go there, we look at it, say, okay, Staph aureus bacteremia within 3 months, great. We don't even need a biopsy. It has a typical imaging there, destruction of the disc, this disc-centered changes, paravertebral changes, small pseudo abscesses just treated with oxacillin. Treated for 6 weeks, multiple calls to neurosurgery. First concerning diagnosis, concern for epidural abscess, without the MRI, without deficits, they're concerned. Pain, pseudo weakness, which is another area that we're studying. What's the economic value of so-called pseudocaudocquina syndromes that we see in the ER all the time? So the patient's not really weak. CT gets repeated, shows interval worsening. There was a frequent call, etc. You guys know the picture. I'm sure it happens at your hospitals too. But this is what happens. I mean, this is a large lady with weak bones. This is over a year. You can see the disc eventually getting completely resorbed and the lady developing this ankylosis. So L2 and L3 have fused together. And this is where we began, and this is where we ended. So we started with this pretty significant destruction, some loss of height. Yes, we ended up with a small kyphotic deformity on this full spine radiograph that is tolerated by the patient really well. The patient has no back pain. So this is a success story here in the treatment of discitis. And this should be the rule. This should be 80% of all discitis patients. That's what we see. The only intervention really is a biopsy. As far as operative indications, when does it deviate from that course? There are 5 indications for operative intervention PVDO. Diagnosis, neurological compromise, treatment failure, instability, and deformity. The preferred techniques for all 5 of these indications is minimally invasive, and it works really, really well with the first 4 indications. For deformity, what we found in our series is that it doesn't work very well, and we're going to talk about it. But keep in mind, these are sick patients. It's an infected field. So minimizing that space is so important. And there is usually not enough osseous destruction to justify instability. We're going to talk about the rationale for surgical reconstruction. But even with some bone destruction, there's usually not enough substrate to cause instability. So this is really an example of how it should be, a tubular approach for drainage and diagnosis. Here's the case example for that. This is a patient with lower thoracic discitis, prevertebral abscess, same thing, some epidural phlegmon, operated through a tube, needed a second evacuation because of recurrence of the infection. Infection failed to clear. And eventually had 12 weeks of antibiotics, and it finished healing. Bacteria was MRSA. So this is how another 15% of cases should go. If there is a surgical intervention, it's for biopsy, perhaps a little drainage. The treatment of deformity. Well, just before going to deformity, just a word about instability. We're going to talk about the rationale for the treatment of instability and deformity being anterior column reconstruction. The treatment of instability in most patients is just short segment fusion. People are very concerned about approaching it from the front because of the things being stuck to the disc and whatnot. We found that not to be a problem. We just support our general surgeon who's approaching it, or if you're doing the approach laterally or in any way, you're going to be fine. It's never really stuck to anything. If anything, it creates a plane. Once you start treating deformity, you'll see with VCRs, then you get very facile at separating these planes, and it goes a lot smoother. So as far as deformity goes, again, the preferred technique is the least invasive that provides durable relief. I'll show you a few cases of what we call the Black Mamba effect. For those who don't remember, this is from that movie Kill Bill, where the example is given of somebody who gets bit by this African snake that that in 7 days is going to die. This is the poorly performed fixation for post-infectious deformity. We know where this is headed, and I'll show you a few examples. Besides this, if a fusion continues to fail very frequently, there is persistent infection. So it creates a niche for these bacteria to survive. That area of fibrosis, instead of fomenting fusion and whatnot, it creates actually a little haven for the bacteria to survive. And frequently you see these failed cases, pseudos, after fusions for Discitis. In reality, there is ongoing infection. And again, the rationale for all of this is anterior column reconstruction, because it's a sharply kyphosing pathology, and you need to preserve sagittal balance as much as possible. So here are some sad examples of this. So 50-year-old, 2 years of antibiotics. This patient is actually 5 out of 5, despite that curve. A terrible situation. The record in terms of antibiotics, I'll show you the case, is actually 13 years on vancomycin. Somehow you still had functioning kidneys, but it's not an uncommon situation. Another example, 56 years old, Staph aureus, 3 years treated Discitis, multiple episodes, recurrent Discitis. And no, it was the same Discitis all over. It was just they created a niche in order to be protected. This is the example of the patient with 13 years of vancomycin. This thing eventually drained through the skin, so it created this abscess in the disc space, and the patient was paraplegic by now, but he kept draining all the way out to the exterior. This patient would once every couple of years become septic, and then they would do something about it, but never really treat it completely. This is one of my favorite cases. This is a patient I tracked as a resident initially for over 10 years. A 60-year-old starts with 4 or 5 Discitis due to Staph aureus. So gets a small posterior procedure done, doesn't work. Gets an A-lift done, doesn't work. There's collapse. The patient is frail, debilitated, deconditioned. Then gets a posterior fixation without grafting in the front. Fails, the fusion comes loose, rods fracture. So now you have an overlap of persistent infection, osteoporosis, PJK, rod fractures, frailty, deconditioning. That's perfect, right? And so this eventually gets turfed downhill to the younger person in the group. And again, if you have a deformity practice, this is right just down your alley. So this is what we learned after treating. Out of those 298 cases, we had 20 cases that really required extensive reconstruction. So really, just a very small minority of cases, these patients become extremely debilitated. From those series of patients that we treated with 3-column reconstructions, 80% of them have been bedridden for 6 months. So none of them are acute Discitis. These are all chronic Discitis. 70% of them had a neurological exam. They would be strong enough to ambulate, though. So they had 4 out of 5 or 5 out of 5 in the lower extremities. There is an inability to compensate for this deformity. There is an overlap with instability, but the reality is these deformities tend to be quite dramatic in magnitude, and they have very fast onset, so patients cannot compensate for it. They become very frail, and it keeps getting worse because of deconditioning. And on the other hand, because these patients, they stay on the radar, as long as they stay on the radar and they don't fall outside of the health network that you may have in your community, these patients don't die because the infection responds some to the antibiotics. We'll come back, you look at it, oh, it's too sick to have surgery, get 6 weeks of antibiotics, gets better. So the infection remains relatively suppressed or contained, and so they don't either get better nor they die. What we learned doing these cases is that basically we've had every possible complication in the deformity practice, and it's been great for us as surgeons to learn these things and to revisit some concepts that we had. So the initial thought we had, well, open versus MIS, and they say, well, it's infected, right? Let's do it MIS. Let's do the least invasive procedures. Well, we realized that these patients, they did really poorly when you instrumented them without grafting, without durable grafting. And you would think, well, but how often do they really integrate this graft, and how useful is it really? somehow these patients, once you graft, we're big users of bone morphogenetic protein, and it does work. But if we didn't graft, you can see this case here where we did a big anterior approach. We placed the screws percutaneously in the back. It started loosening up the screws very early at 3 months. We reinforced it with pelvic fixation, and still, this is what ended up happening. So now the plan that we have in our rationale, we have a couple more cases like this, is to plan for solid fixation and plan for stable grafting, no matter what. What we also learned is that we need a specialized team to take care of this. It just can't be anybody. You have to have either special preparation to come and work within the group, or some say psychiatric pathology. But you need to have willing radiologists who are able to do biopsies, able to do MRIs when you need to, anesthesia partners who won't freak out when they see patients who are this sick getting this much surgery. The most that we've lost in one of these reconstructions, a vertebral column resection, resect the infected area, resect the bone and correct the deformity. The mean EBL was 3 liters for these surgeries, but we've had patients lose as much as 11 liters in a patient with cirrhosis that we have there in our series. So patients, anesthesia partners have to be prepared for this. It can't be the guy doing tonsillectomies every day. Your ICU needs to be able to manage a polytrauma case, which was an eye-opening fact for us in our ICU that deals with predominantly strokes and vascular neurosurgery. So this was great there. And then infectious disease partners who understand your guidelines will manage the treatment, will manage follow-up, and you will have prompt communication with them. These need to be guys, okay, who support you, but also you will pick up their call when they're calling and asking you to see a patient right away. Even if it's nothing, you will work with them, right? We learned that these procedures, they are extremely morbid. We also learned that the risk stratification tools cannot accurately predict the morbidity. So we need new tools to predict exactly what's going to happen. We've had these patients go through the regular clearance process, and we've had numbers given since 0.4%. Like somebody looks at these patients who are bedridden and say, okay, low cardiac risk. It doesn't have chest pain because it can't really walk. I say, of course, patient can walk. The patient is bedridden. That's insane. Or you've had patients go into the MELD scores for cirrhosis. That particular patient who had hepatic insufficiency had a 50% mortality rate predicted by the team, which is also not true. The patient ended up eventually getting a liver transplant too, and is living a perfectly normal life. What we found that correlated better were the immediate postoperative scores. And out of that, the SAPS-2 was the score that predicted the mortality the best. So the range, so for those of you who don't know, SAPS-2 is a physiological score. You have online tools that you can calculate in any patient the first 24 hours post-op. They look at parameters like bilirubin, creatinine, urinary output, and you calculate, we come up with a number, and there's a normative curve of mortality in the first 90 days. So our SAPS-2 score, the predicted mortality was 15%, but actually 1 out of 20 patients passed. So we're doing a little better. And just to give an example of the magnitude and the physiologic load to these patients, our cervical 360 reconstructions had a SAPS-2 of 15. So this is quite more morbid than patients having reconstruction for cervical morbidity, for cervical deformity. We had a 100% complication rate, most commonly transient hypotension, post-op anemia, small PEs, DVTs that are normally just found out in a patient who has some tachypnea post-op. We're very aggressive with CTPE protocols because we want to anticoagulate these patients quickly. And then you find some small PE, and it may not be even significant, but our patients come out of surgery with big drains, so we anticoagulate these patients. But it ranges. We had patients come out of surgery with 3 vasopressors, and we had to take them to thrombolysis right away and take out big clot from the pulmonary artery and whatnot, and then they do well. So it can range the gamut of PEs and DVTs. And we treat these complications very, very aggressively. On the other hand, these are extremely rewarding cases, right? So these are cases where you have to use advanced deformity techniques. Like, for example, this case was reconstructed completely posteriorly. This patient had radiation to the abdomen. due to pancreatic cancer, had a Whipple, so the abdomen wasn't available to us. So we removed that A-lift cage through the back, placed that VCR cage over there, reconstructed. You can see every deformity technique in the world. We had PJK. You can see there's a connector in the upper thoracic spine. That's where we originally stopped. So then we had to extend into the neck. We had a 25% reoperation rate due to predominantly osseous complications. So PJK, distal failure, pseudoarthrosis were the main reasons for reoperation. We had some infections there, some wound infections, but those were minor. We had 3 out of those 20 patients return to work, and actually 17 returned to ambulation and self-care. And that's within, I know ODI, it doesn't really apply to this, but we collect the information, just gives you a magnitude of the improvement of quality of life. So I'd just like to wrap it up. I know it's been a long time talking about Discitis. This is one of our patients who was intubated for a week. They were letting some person make decisions, decided to place her in hospice care and whatnot with a Discitis and epidural abscess. She was quadriplegic and, got a reconstruction and did quite well, beats hospice any day over there. She's completely insane, but she is living the life. PVDO can be a very, very rewarding pathology to treat. It's one of the few areas in spine surgery where the application of evidence-based medicine is still lagging. It's our responsibility to foster that. We should foster it, not let other specialties foster it for us. 90% of the cases will be treated with biopsy only, 80 to 90%. The other cases will be predominantly treated with minimally invasive techniques, and extensive reconstruction an absolute exception to the rule. Basic spine surgery principles, good arthrodesis, good fixation, adequate alignment, they apply. It's not an excuse that you're treating an infected case or some patient is very frail to forget these principles. Should always plan for the long run and never, never, never give up on these patients, because I'll tell you, they keep coming back. If they remain having access to antibiotics, they just don't pass, infection gets contained, and what you don't treat today, you're going to be treating next week. So I'd like to thank you for your attention. Here's my email. If anybody has any questions or any comments, criticisms, I'm open to any of them. Thank you.
Thanks, Ricardo. Well, that was an outstanding presentation, a must see for all residents and fellows. That was a great review. I have we're on time, so I have a short question. We have learned that infection need to be treated with both antibiotics and stability. That was the best strategies. When you need to do fixation, internal fixation, and when you can do an external orthosis. You look at the kyphosis, you look at pain, you look at the pathogen. What are the main indicators for doing fixation, even percutaneous or open?
Right. So I like the CT. Okay, so when there's evidence of extensive osseous destruction, that thing's nice. You look at the gap between the end plates and you say, listen, that's not going to work. So osseous destruction is a big determining factor. You look at, if there is deformity already established, well, that's not going to get better. There are certain parameters that you come to learn, like, for example, so these are predominantly thoracolumbar, right? So, patients can tolerate about 10, 20 degrees of kyphosis across the thoracolumbar junction without problems. So you say, I can wait, I can keep an eye on this, and I can just instrument later. But the general rule, by the time there is misalignment, be it translation or be it excessive kyphosis, you're just better off just reconstructing it right away. Nobody wins. And you're right. I mean, you need stability for everything to knit together. And so if there is already evidence of instability, you're done. And so that's how I think about these cases. How do you think?
On the other hand, I think this mild deformity flexible. It's easier to treat than late fixed deformity. So right. Both things matters when you consider that. That's what I think about how you have much more experience on an infection that I have. So that was great. I don't know if Matt Goodwin is there and have any question, or anyone in the audience. You can raise your hands. Otherwise, I want to thank again Ricardo. That was phenomenal. We'll be online on our YouTube channel for I think tomorrow. So I will share the link for anyone.
All right.
I really appreciate your lecture. Thanks anyone for coming tonight. We'll see you next week for a weekly session or virtual global spine.
Excellent. Well, thanks again, guys, for the opportunity. Alfredo, it's always great to see you. Hope to receive you over here. I'm building a whole new pahilla over in my house. So it'd be great to receive you here in Chicago and anywhere else.
Sure.
Thanks
I'll
again,
be back
guys.
then.
Have a good evening.
Good to see you.